So pre-oxygenation is before induction. I always give so that in case there is a delay in securing the airway, can avoid the patient going into hypoxemia. That is the main purpose of pre-oxygenation. And in cases of difficulties in ventilation and intubation, it is unpredictable. This is decided in almost all patients. And during emergence also, earlier it was considered pre-oxygenation is important during induction and intubation only. But nowadays they recommend that you oxygenate the patient well before you extubate the patient, because sometimes there may be residual effects of anesthetic and inadequate reversal, which may lead to hypoventilation and hypoxemia. And routine pre-oxygenation before the tracheal extubation is nowadays very much recommended. And most of you know that before reversing the patient, we always cut all the anesthetic agents and give 100% oxygen, and then only reverse, so that that acts as a oxygenation before extubation also. And the effectiveness of your pre-oxygenation can be assessed by two categories. One is by efficacy and other is by efficiency. And the indices of efficacy are increase in fractional alveolar oxygen, which of course we cannot directly measure, but it increases the arterial oxygen tension. So if you do a blood gas analysis, you will be able to find out the increase. So what will be the normal of arterial oxygen tension if the patient is breathing room air? Dr. Kayal? 100. 95 to 100. Yes. Okay? So if you give 100% oxygen, what should be the arterial oxygen?
100 millimeter of mercury.
Only 100. Room air itself you get 100.
Yes, sir.
The patient is breathing 100% oxygen. You are giving pure oxygen only. What should be the arterial oxygen tension?
More than 100.
How much? More than 100 can be 1000, 1 lakh, 2000. Is there any way to calculate that? How much of oxygen a patient inhales if you are breathing room air? What is the concentration of oxygen in room air?
21.
Percentage. 21% or 20% roughly. So for 20%, you expect a arterial oxygen tension of 95 to 100. So for 100%, what should be? Roughly 5 times.
Yes, sir.
Okay, it should be anywhere between 450 to 500. Okay? So that is how, this is a common question they may ask you in the exam. Room air, you expect 5 times more than the concentration in room air. 20% becomes 100 millimeters. So 100% should be 500 millimeters. If it is less than that, that means something is wrong. Either the oxygen carrying capacity is low, or the oxygen is not being delivered properly, FiO2 is decreasing. So that is the important thing. So you can measure this only by ABG, not the saturation. And there is a decrease in the fraction of alveolar nitrogen. This also can be calculated only by laboratory method. So this is the most ideal method of measuring. But what is the non-invasive method of measuring the efficacy of your pre-oxygenation with 100% oxygen? So patient end-tidal oxygen, expect very good. So normally end-tidal oxygen will be very low, because whatever oxygen you are taking will be utilized in room air. Once you start increasing the FiO2, all the FiO2 cannot be utilized. So it will start coming out in the expired air also. So there will be an increase in the end-tidal oxygen concentration. Normally, we measure end-tidal carbon dioxide concentration to find out the adequacy of ventilation. So, if you want to find out the adequacy of preoxygenation, you have to measure the end-tidal oxygen concentration. Okay. So, end-tidal oxygen concentration of 90% or more, the end-tidal nitrogen concentration of less than 5% is considered as the maximal efficiency of value. And efficiency is the rate of decline in oxyhemoglobin or desaturation during apnea. That is called the efficiency. So the various maneuvers for preoxygenation, all the things he has mentioned. So apneic diffusion oxygen, continuous positive airway pressure, deep bilevel, deep BiPAP, drive, and what are the benefits of apneic diffusion or maximal pre-oxygenation? Maintaining airway can achieve them only by maintaining a patent airway. That's very, very important. If the patient has a high functional residual capacity to weight ratio, that will also improve the oxygenation. And the risks of pre-oxygenation, you have given 100% oxygen for quite some time, and then even if you have passed the tube into the esophagus instead of trachea, it will take a longer time to detect because the patient will not desaturate immediately. But on the contrary, the EtCO2, how many tracings of EtCO2 are considered as the gold standard for tracheal placement, correct tracheal placement?
3 breaths.
Six tracings, minimum 6 tracings. Okay, it should be a normal EtCO2 pattern of minimum 6 tracings should be there in the EtCO2 graph. Then only it is considered as the correct placement of your tracheal tube. And it can lead to absorption atelectasis, production of reactive oxygen. What is this reactive oxygen species? What do you understand by this? All of us say reactive oxygen species.
Free radicals. Produces free radicals.
Produces?
Free radicals.
Free radicals. Okay, what is free radicals then? Next question.
It is toxic to our body. Toxic to our cells.
Entire cell?
Causes autoimmune reaction.
Autoimmune.
It is toxic to our. It is toxic to our cells.
It's toxic to which part of the cell? The entire cell, the cytoplasm, nucleus, mitochondria, or the cell wall?
Mitochondria.
Read about it and tell me in the next class. Okay?
Yes.
Read all about this. It's a very, very important topic. You should have no confusion about that. Undesirable hemodynamic effect. And physiological basis of all these things is, so these are all the various volumes of oxygen that you will have in breathing room air. So it increases. The lung, it goes to the maximum. The FRC is totally replaced by oxygen. So normally the examiners ask you, how do you have 450 ml when you are breathing room air? How do you get 3000 ml when you are breathing 100% oxygen? Can you tell me how? Kyle?
Sir.
How do you say that there is 450 ml of oxygen when the patient is breathing room air, the lungs? The lungs means, is it in the entire lung or which part, which capacity of the lung is?
FRC.
FRC, functional residual capacity. What is the importance of FRC? What does it serve?
It increases the apneic time.
In your normal respiration, do you go for apnea?
No, sir.
FRC is present in your normal lung itself, isn't it?
Yes, sir.
What is the purpose or function of that FRC? It's normal respiratory physiology question.
It helps to take next breath.
Help to take
Next breath that already
next breath.
inflated lung.
How do you divide respiration? What are the components of respiration?
Inspiration and expiration.
Inspiration and expiration. During inspiration, you take the atmospheric air into your lungs, which contains 20% oxygen. After you inspire, you expire the air, isn't it?
Yes, sir.
So where will the body get the oxygen during the expiration?
From FRC.
From FRC. Okay. So during expiration, air is flowing out from your lungs. During that time also, heart is pumping and blood is constantly circulating in your pulmonary vasculature. So unless you have some reservoir like this functional residual capacity from which oxygen can be continuously taken up for the tissues. So that is the most important function of FRC. That is the function it serves. It supplies oxygen to the body or the blood during expiratory phase also. That is the most important function of functional residual capacity. And what is the normal adult patient volume of FRC? How
1500.
many liters? 1500. It's more than that. It's roughly 2500 ml. Okay, or 2.5 liters is there. And this 2.5 liters, if it is filled with room air, how much oxygen will be there?
21%.
21 out of 2500. That
It's
is roughly about 500. It
Yes.
is given here as 450. Okay, 1/5 of this 2500 ml of air is oxygen. So when a patient breathes room air, the functional residual capacity contains roughly about 450 to 500 ml of oxygen. The rest are all nitrogen because it is air. On the contrary, when you pre-oxygenate the patient, gradually what happens, this room air gets replaced with 100% oxygen and the entire 2500 ml becomes oxygen only. That is how the value increases to 3000 ml. This actually should be roughly, if it is 3 liters, it will be 3000. Okay. So that is how the oxygen content increases. The FRC plays the most important role. If you see the increase in other structures like blood, there's only 100 ml increase. Dissolve becomes double and combined with myoglobin remains the same because it cannot improve. So the FRC getting replaced with 100% oxygen is the main source of oxygen supply even when the patient is not breathing. So the FRC normally supplies the oxygen during expiratory phase, but after induction and paralysis, the FRC, which is converted into 100% oxygen, forms the main store for supplying oxygen. So it will increase the duration of say apnea anywhere. A person's normal oxygen requirement per minute, how much is that? How
250
much of
ml.
oxygen? Huh?
250 ml.
250 ml we require. So if you are breathing room air and you have only 500 ml of oxygen in that, how long you can tolerate?
2 minutes.
2 minutes. Whereas if you have 3000 ml or
6 minutes.
2500 ml, it can be 10 minutes. Okay? So that is the idea with which we pre-oxygenate the patient. Okay? So the terms pre-oxygenation and denitrogenation, that is removal of the nitrogen, which is part of the air, is used synonymously. So olden days they used to call this as denitrogenation. But why we have now given up this word denitrogenation? Is nitrogen present only in the lungs or elsewhere in our body? When we are breathing room air, which contains maximum nitrogen, 80% is nitrogen only in the room air we are breathing. So this nitrogen, does it remain only in the FRC or in the lung, or does it have capacity to go into other parts of our body? If so, which parts of our body will also contain nitrogen?
Fat,
Ah,
adipose tissue.
fat. Will it go and mix with fat? It will go into all body cavities. It can go into the joints, it can go into the intestinal cavity, because it has a good diffusing capacity. So it will. So earlier days when they said 3 minutes of preoxygenation, they wanted this nitrogen which is present in the other parts of the body other than lung also to come out. That is why they termed it as denitrogenation. But now we don't agree for that, and we say even if you replace the FRC with the completely oxygen, remove the nitrogen, is good enough. So this word denitrogenation is no more recognized or accepted as a term to be equivalent to preoxygenation. Okay. Now the stages. When you start preoxygenating, you are using an anesthetic circuit, and that anesthetic circuit initially will have only room air. So you have to completely remove all that air and fill it up with oxygen by opening the flow meter in your machine, and usually you use a high flow so that you can quickly drive out all the air and then place it on the patient's face and ask them to inhale that. So the first step is to remove all the air from the breathing circuit. That is called the washout of anesthesia circuit. And once you do that, then all the oxygen will go into the patient's lungs, and that will start filling up the FRC, and that will change the FRC content from oxygen plus nitrogen into pure oxygen. That is how the deoxygenation stage happens. Causes of low FiO2 in bearded patients, you may not get a good fit of the mask. So patient may have leak, and there may be patients again having a edentulous or toothless patient. So if the patient has uh, dentures for both the jaws, and when they remove it, they become totally edentulous. Will you allow the patient to wear the dentures or not to wear the dentures?
And allowed to wear.
It's better to ask them to wear the dentures so that you will get a good fit of the mask. So in total edentulous patients, if they are using dentures for both the upper and lower jaw, you need not ask the patient to remove them. You can ask them to come with the dentures in situ. Even if it slips, it cannot enter the trachea because it is quite huge. So on the contrary, it will help in getting a good fix of the face mask to the patient's face. So allow them to wear that. Elderly patients with sunken cheeks, all those who have a hollow cheek, they also will have difficulty. And if you use a wrong size mask for the patient, that will also cause leak and improper use of head straps, which we normally don't use. The presence of nasogastric tube or other tubes will also prevent a good fit. So these are all the common factors for air entrainment. That is, the leak will happen and patient will inhale room air also along with the oxygen that you are giving. And the causes of loss of capnographic tracing. When will you, supposing you measure the EtCO2 right from the beginning of preoxygenation, what are the conditions where you will use the capnographic tracing? Some think of conditions, right? The absence of will be there when there is a lower than expected end-tidal carbon dioxide, and ETO should alert the anesthesiologist presence of leak in the anesthetic circuit. So if you are measuring the EtCO2 right from the time of preoxygenation, and if you are not getting a normal tracing, then you have to think there may be some leak in the anesthetic. Factors affecting the efficacy and the efficiency, all these things are inspired concentration, which is not properly delivered, presence of leak, and the anesthetic system used, which may alter the delivery, level of fresh gas flow, type of breathing, duration of breathing, alveolar ventilation to FRC ratio, and the volume of oxygen in the lung, FRC, all these things decide about the efficacy and common methods of doing the preoxygenation. One is called the tidal volume breathing. This is a normal respiration. Or you can ask the patient to take a deep breath as much as possible, which is considered as a capacity, vital capacity breath. Then it can be followed by normal breathing. Or you can do 4 deep breaths, 4 inspiratory capacity breaths, which is done usually for emergency situations where you cannot do for 3 to 4 minutes, and extended deep breathing cases of anticipated difficulty. And hyperventilation of the breathing can reduce time required to increase the oxygen stores. And the basis of using deep breathing is an alternative to tidal volume breathing. And pre-oxygenation for high-risk patient populations. There are a few patients who run the risk of early desaturation if not given pre-oxygenation. The most important among them is the pregnant patient. So because they have a low FRC, they desaturate much faster because the gravid uterus reduces the capacity of the functional residual capacity, and the pregnant woman, their diaphragm is also splinted by the gravid uterus, and does not allow proper expansion of the basal portions. And 4 deep breathing technique is inferior to 3-minute tidal volume breaths in this. And unless it is an emergency LSCS where you are giving GA, if you have time, it is always preferable to go for 3-minute normal breathing deoxygenation rather than 4 deep breaths technique, which was introduced mainly in cases of category 1 cesarean, where there is a threat to the mother as well as the fetal life. And increase in ventilation as well as the usage of oxygen, much more consumption is higher in pregnant women. So it is always better to give minimum 10 liters flow when you pre-oxygenate, whereas for other patients you can give 5 to 6 liters, that may be enough. And obesity, again, is almost like pregnancy, so they also desaturate much faster because their FRC is also low. And another complication, morbid obese patients may have OSA also, so their airway passage also may be obstructed, so difficulties may occur in their ventilation. And so head up position is always a must for obese patients. And in pediatric patients, more younger the child, the desaturation is much faster because they also go for have a reduced FRC. And elderly patients, they may have all sorts of alteration in the lung, like volumes are decreased, closing volume increases and encroaches on FRC, ventilation perfusion mismatch may occur, and they have reduced pulmonary reserve. So all these things may increase the chances of desaturation. And patients with pulmonary disease also, again the same problem, FRC will be reduced and perfusion also ventilation mismatch also will be there. And the patients at high altitude, they also require a longer duration of pre-oxygenation because the ambient pressure is low there. Potential risks, there are some risks of pre-oxygenation. One is the esophageal intubation cannot be detected early because they fall in SpO2 will take a little longer time, and absorption atelectasis of the basal segments is also can occur, and the increase in intra-abdominal pressure leading to compression of thoracic cavity and airway closure, and production of reactive oxygen species. Oxygen is a paramagnetic atom containing 2 unpaired electrons, so it makes them very highly active to form a dioxygen content. This is the answer for that. the dioxygen molecule can accidentally or deliberately split, producing reactive oxygen species, which include superoxide anion, or hydroxyl radical, or hydrogen peroxide. So reactive oxygen species can react with critical molecular components such as lipids and the other causing significant cellular damage. So the bilipid layer of the cellular membranes will be affected by reactive oxygen species. And the clinical manifestations are pulmonary edema, acute respiratory distress syndrome, retinal detachment, and retinopathy of prematurity and seizures. And because of short duration, cellular injury due to reactive oxygen species would not be applicable to preoxygenation. So only prolonged high oxygenation will cause this particular problem, which is a part of oxygen toxicity. Cardiovascular results are most decrease in heart rate and decrease in cardiac output, and it may cause blood pressure to increase. Decrease in coronary flow can happen. Hyperoxia can cause a marked decrease in coronary blood flow, which is reflecting vasoconstriction, and inactivation of nitric oxide, another vasodilators released from the vascular endothelium, which causes closure of ATP sensitive potassium channel. And the inhalation of high oxygen can reduce cerebral blood flow also because of vasoconstriction. And PaO2 is increased by inhalation of 100% oxygen. Then carbon dioxide dissociation curve is altered. So there is a reduction in affinity of blood for carbon dioxide. So carbon dioxide accumulation can happen in the body. So these are the answers for preoxygenation.